we are all, for the past 3 months in the webinar, we are all focused on coronary interventions, basically coronary imaging and physiology. So I would like to thank Dr. Aravind Kumar in bringing a topic which is more popular in the West, that is structural heart interventions, which requires mostly transseptal access as the cornerstone. And I would invite you to start the lectures. I think about 15 people have already joined. So with the permission of Dr. Aravind Kumar and Dr. Ravindran, thank you, sir. Thank you for accepting. I think Dr. Ravindran can introduce you better than me because he is known to you personally.
Already, Ganesh, and I think we'll go into the lecture in the end. Maybe we should all interact because he will make the things very lucid for us if any doubts are there.
Sure.
Thank you, sir. Over to you, sir.
Yeah. Thank you, Ravindran. And so I'm here to, thank you. I've visited Trichy, I think, when that was 3 years back now, Ravindran. It must have been 3 years now.
Yeah,
beautiful city, and I really liked it. This must be like a tri-city, this must be some tri-city CSI, you 2-3 cities together, you have a CSI, very good. Yes, I'm happy to see people from all these places. I really liked, I think, that one day we did some cases in Ravindran Center, and some of them were structural. So I'm happy to be here. So I'm going to discuss about transseptal intervention, not too much about intervention. I want to discuss actually more about transseptal puncture itself, because that will be the basic for all the transseptal intervention. Each intervention obviously has its own plus, its own minus, its own way to do. But I think what is common to all of them is a transseptal puncture. So let's go with simple things, what we do, and then understand what it is. I know it's very late already. I hope all of you had your dinner, but anyway, I won't keep you up for a long time. So this is something which is evolved. Lots of senior people in the group must realize, definitely know that first first LA pressure was actually taken through the bronchus. From the left bronchus, they passed a needle and measured LA pressure. That is the way, because echo was so primitive that time. They didn't have septal puncture and such techniques, and it looks very gross if you think now, going through the bronchus and getting a LA pressure. But with the E-bus coming back now, again there is more interest in entering those paths. Septal puncture initially was diagnostic when people wanted to know the LV pressure, LA pressure for AS, because then the echo was very primitive. But with development of echo and probably with development of percutaneous balloon mitral valvotomy, the interest in septal puncture actually came, and it became transseptal access to enter LA. And most Indian, cardiologists are extremely good at fluoro-guided transseptal puncture. They have a lot more experience, I think, much more than West. Then came pulmonary vein isolation, AF ablation. Again, most EP people are good at it. They're able to do even better than us because they do it on nearly normal heart, and they have their own tricks and tips to do that. They use coronary sinus catheter as a guide, and they do it. Then came a lot of intervention, which included left atrial appendage closure, which has been there for some time now. Now we have catheter mitral valve implantation, like a valve-in-valve. We have mitra clip, paravalvular leak, and even LV devices. So it's needed for variety of intervention. But I think the trick is to learn a good septal, puncture. So I'm going to spend little time in understanding that, and maybe that's something which we should master, knowing very well that the scope of this procedure is only going to increase with time to come. So, and as I keep telling Ravindran and everyone, see, whenever we think of a procedure should be split into multiple small steps, and we need to master those small steps. So when you do that, the actual procedure doesn't become big by itself. Otherwise, every procedure, you think of TAVI, you think of LA, you think of any procedure has 4 or 5 key components, and you could be, when you're doing it for the first time or when you're under stress, you could actually it could be very confusing, and it could be difficult for people to do. So always, in your mind, divide it. For example, tomorrow if you want to do a TAVI or a aortic stent graft, master per close, because that's something which it's going to happen. So master per close or LV entry. What we did, I'm sure Ravindran will remember, is whenever after, once we knew TAVI is going to come, even 3 years before, make sure you cross aortic wall, learn the steps of crossing the aortic wall, and measure the pressure gradient. So by doing that, that 2 of 3 of the steps are actually done and things are easy. Same way when it comes to septal puncture, there are many procedures, but master septal puncture right away. If you master a echo-guided septal puncture, which is TE-guided septal puncture, half the work is done. Because imagine you're doing a mitral valve replacement and you're struggling at the septal puncture, and because of the wrong puncture, everything is wrong, it becomes tough. So we have lot of chance to do that. So I would actually suggest that this is something which we should do. So some cases are definitely complicated, and all of us go through that, including aneurysms, huge LA, huge RA, reverse RA big, small LA, which is a challenge by itself. Kyphoscoliosis, IVC interrupted, dextrocardia. There are so many conditions where it becomes difficult. And first attempts look like this. You don't know where you are, and you're just firing the arrow. So let's go through the fluoroscopic technique first, which is very simple, but you could do little modification in the fluoroscopic technique. I'm going to just maybe go through it, so that fluoroscopically also your septal puncture becomes better and safer. Now we know that broken burrow needles are key and they are available anyway. And then you need a sheath, which could be a SL1 sheath or a Mullin sheath. Either of them is fine. You get them in different shapes and different sizes. When for BMV, typically we take only dilator, because you just have to pass the 018 wire through that. Here, most of the time, when you're doing a therapeutic septal puncture, you need both sheath and dilator, and typically the sheath is taken in and this is measured. A sheath with hemostatic valve are preferred, because you don't want to introduce one air into LA, and you want to measure this one. So it's better to have a sheath with the hemostatic valve. Yeah. Should I wait a minute, Ravindran?
Somebody's TV is playing, sir, in the background. I'm trying to mute them. Is there any person, technical persons? Could you meet all the participants?
Yeah. I think it's okay, Ravindran. Yeah. So with this is how it looks. I am sure all of us have seen this, and there is no problem here. And what do we do? There are various methods available. For historic reason, I'm going to talk about Innova method. But this is something which is septal puncture is one of the toughest procedures. I mean, for all of us who have done here, you realize that we have all lost night's sleep over septal puncture. I remember my first BMV, which I had to do independently when I was in KMC Manipal, and I remember not being able to sleep the previous night because this is such a complicated procedure. Coronary you get to choose, here you don't get to choose a lot, so it is difficult. If you go by bucks, you get all this complicated midline technique and angio and all that. Practically you realize that there's no much role for all this. It looks very complicated, and all this makes very complicated. I must have read, before I did my first septal puncture, I've read this maybe 3-4 times just to understand what it is. Finally you realize probably you don't need all this. All you need is little common sense and little understanding of where LA is and where RA is, and also realize that when there is double shadow, you need to be inside the inner shadow, because septum is between two atrium. It can't be outside this. When there is double shadow, you will have to be inside the inner shadow, but outside the midline, the mid septal line. You have to, that is the area which you want to do. And this calculation probably is not needed. There are angiographic methods, and it probably is not needed at all. So let's go through instead of going through all this, anatomy is what we understand, that fossa becomes an important area. Even when we talk about inferior posterior and posterior and whatever, which I'm going to use those words, but we should remember it's still in the fossa, but not at the mid fossa. You still want to puncture all your punctures during, in the soft, in that a thinner area. You don't want to puncture in the thicker area because that itself produces lots of this. So remember, you have to be in thinner area. So imagine if you take a CT like this, and then if the image is taken, and imagine there is on the septum you draw a clock which is 12,396. Now, where does the septum lie? Septum typically lies at 2 to 7 o'clock. So what is this 2 to 7 o'clock? This 2 to 7 o'clock is a marker in your broken barrel needle. So you want the marker to be between 2 to 7 o'clock. Most of the time when you puncture, it won't be at 12. It won't be at 9. It will be between 2 to 7. Almost all the time when you puncture, especially when you puncture fluoroscopic. Now, and also it's very important to introduce the broken barrow needle at 12 o'clock. People tend to rotate it there. I recommend you don't rotate. Keep it at 12 o'clock. Take it in. Any resistance, the broken barrow can easily come out of your other sheath. Any resistance, it's okay to follow it through fluoro and come out, and you're going to puncture. The typical puncture is 4 to 6. So this is how it looks in a watch like this. This is how it looks. Next, you need to understand is, if at all, if you move clockwise here, how will it move there in the heart? How will it move? Will it move clockwise or will it move anti-clockwise? And depending on the bulge, you may have to puncture between 6 to 7 o'clock. Typically, if it is a normal LARway like the EP puncture, it's between 2 to 3, or maybe typically it is at 4 o'clock. You don't go beyond. But in the case of bulging septum where RA is slit-like and more bulge, your puncture actually goes much more this side. So you could be shifting it here or there. So, but you're between 3 to 6 o'clock most of the time. Now, this slide is probably important for us to understand how to puncture for a different anatomy, but please note you're still in the fossa. Whatever people tell you, you're not in the hard area. You want to be in the soft area, but in soft area, you want to cheese, because fossa is not the point. Fossa is still a big area. It's almost completely formed by the septum, and this is where you want. So if you look at this diagram, blue is where a BMV puncture is done. Why? Because you want to enter into, that's like a mid puncture, and you need around 4 centimeter. That's 4 centimeter. The BMV, the extended balloon, Innova balloon is actually 4 centimeter. So you need around 4 centimeter from here to reach the mitral valve. And mitral valve is anterior. A central puncture will help you to go to the mitral valve. So the blue is where actually you want, you want the BMV one, or also any procedure where you want to enter directly into LV, close LV. Blue is where you want the puncture. Now let's understand how to reach blue. That's next. But let's understand where the puncture should be. So that should be blue. Whereas red and dotted red, that's where you want to go for mitra clip, because mitra clip is 4.5 centimeter. It's 0.5 bigger. So you need to be slightly more superior, but you need to be in the same line. You still have to enter LV. So blue and dotted is where you want to be in mitra line. The green is for LA appendage closure. That means it is posterior and inferior, So you have SVC, you have IVC in this picture. So by coming here, you are away from aorta. That means you're posterior. And here you are inferior. You're very low down. And orange is for pulmonary vein, because you need to go anywhere. It's inferior, but little more anterior than this. That is where the puncture of this is needed. So based on this, once you have a fair idea where you want to puncture, we'll come to tips and tricks to localize that area. But in your mind, you should always think things go straight. So you need, if you're going inferior, you need a superior puncture. And if you're going posterior and up, then you need an inferior puncture. So that's what you need for all of this. Okay. Now let's do the simple fluoro guided procedure. So what we have done is after I have changed my own technique slightly. Initially, I used to always put a pigtail and then do the fluoro guided puncture for BMVs. Now I don't put pigtail at all. I do it because after doing for LAA and although even when I'm not doing flow the TE, you get an idea. It's like, after if you do a several IVS guided angioplasty, after some time your eye gets trained even for a fluoro. Your fluoro also you have an idea how the structure appear. So I did change my practice a little after LAA closure. So nowadays, when I do a septal puncture, even for BMV under fluoro guidance, I do not put the arterial catheter. And believe me, that has made my procedure easier. Even when I have to do angio now, I do a angio, radial angio most of the time, but I don't put a pigtail because I realized moment I put pigtail, I just come one vertebral space below it. I'm very confident of my position, and that puncture which I do is not very optimal to enter LV. Once I stop putting that pigtail, my septal puncture has become more optimal and I'm able to enter LV much more quicker, and the procedure time actually has come down. Otherwise, the steps are same. You go straight to SVC, you come down, and this is where you want to enter. You want to be in the mid PFO area to enter. All of us know this system. Let me just show the fluoro to enter. If you put a pigtail, you know how it is. You need to check in two views. If it is only fluoro, you need two views. One view not possible. Now people do different views. It could be RAO, LAO, lateral, they could use that. I know people who are puncture throwing RAO because it looks anterior. I personally prefer the puncture to be in LAO or lateral. I've made it LAO now, but initially we started with lateral. Basically, to understand, you want to look at the septum and you want to look at the spine. And because LA is the postermost structure, you want to look little up towards the spine. So my puncture typically is in LAO. Once you're in LA, always confirm. You can be, there are, sometimes lots of, you may be into a lot of surprises, but if it is a small catheter, small wire, small puncture needle which has gone into, even if it goes to aorta, it is okay. Problem comes when you put jalebi wire or Innova wire and dilate it. If it is just this much, it is okay. This is one of our case showing the septal puncture. So what we have done is we have come from way up, we are coming down, dead AP view. As we come, you can see that first, you can see the double atrial shadow here. You can see this, the spine here, and you're also seeing the first bump here. Would I puncture here? No, I would go way down. I would come. If I have to puncture, that would be somewhere here. This is the point I would puncture. So I now look at the point where it turns like this and puncture that turn. When you do that, you realize you're almost at the PFO area. If I have a pigtail, then I become a little more confident. I end up puncturing little higher. So coming little down is better. When you come down, doesn't mean you come inferior. When you do the TE guided thing, you realize it may not be inferior. And to puncture, we always look at RAO to see that it is anterior, and then look at LAO. The puncture is done in LAO, where you are actually focusing at the spine and you are entering. And as soon as you enter, you measure the LA pressure, put your Innova balloon, dilate it with Innova balloon. And I just want you all to, this is nothing great, but the ease with which you are, BMV enters, once your puncture is good, the ease with which it enters is actually very, it's actually very rewarding. My time for entering into LALV is become much lesser. Once I started this technique, the struggle is almost never there. You're just there and you're just entering. This is how easily it enters, even if it is severe MS. Now, TE guided, I think that's why we are here today, because the rest of the things most people do, how to do a TE guided puncture. I think most important thing is to understand that TE guided is needed. How many, Indian cardiologists, especially in busy centers, have done enough BMV, and they do 4 or 5 a day, and that kind of load is done. But when you have to learn a septal puncture, TE guided, relearn it. Don't think you've done so many in, using different technique and you're so confident of doing. It's a new art. There is a new learning curve. It's, if at all, much more safer, but you need to learn this. It's important to learn this. Sometime, when I go to Proctor for LA, this is the, especially in the busy center, this is the problem. Before you turn this way, they would have put aortic needle, aortic pigtail, and they would have punctured LA because they think they're very confident of doing it. It's true that they are confident, but you know, we should realize that the blind puncher, you just don't know where you are. And as you compare, you realize that you are actually wrong. When you think you are inferior, you're not really inferior. You could be quite superior. So for that, you need this you know, bike, just two views, and you need to talk to your echocardiographer. Nowadays, you realize that we don't do under GA, we actually do under Dexmed, which is a drug for which is very comfortable. People are, you know, people listen to you with that, no intubation. And you can even use pediatric TE probe, because the herds of pediatric TE probe and adult TE probe is same actually as far as that, but it's much smaller and people tolerate it well. So you could use either. It's very comfortable. So how do we do that? Look at this. See, if you see this view, it's a one view, you can see a tenting. So this is a bicaval view. SVC is here, IVC is here, and you see some tenting here. Now this is a midpoint tenting. You may have to, you know, there is a learning curve both for you and your echocardiographer. It's a two-person procedure. Should remember, you need to talk to each other, whether it's one more cardiologist or a sonographer. And also you should understand that people would have done lots of TE, but when you do a therapeutic TE, you know, in the sense, when you do TE for therapeutic guidance, it's different from what they do, because other TEs are just put up and down, look at LA clot, look at pulmonary veins, margins of ASD, and you come out. Here, no, you need to pick up the catheters which come in. So there is a little learning, but it's not tough at all. Look for that tenting. Once you see that tenting, you do the septal puncture. So here, if you see, there is a bicable view, and you can see the tenting. It's the short part of the PFO, I mean septum. It's thin, and this is where the tenting is seen. This is where I want to go. I don't want to go too low down also, because then there will be a very thick septum, which will be difficult to manipulate. So this is where we want to go in bicable view. So this was a LAA case. So the puncture we want to be inferior. What is inferior? Near IVC is considered inferior, and what is posterior? Away from aorta. So in if you do its fluoro, you keep coming down. TE probe is already in, patient is not intubated, and you keep coming down. As you come down, you know, sometimes even this position is down. You don't realize it unless you see in TE. Even this position is actually down, and then you go to aortic view. 30-degree aorta, which we are all familiar. And this point, you don't go up and down. That same broken burrow, the pointer which we discussed, you turn it more, you know, clockwise. Remember, clockwise. As you turn clockwise, you see your needle going away from aorta. Away from aorta will be posterior. That means if you want a puncture for a you know, LA appendage, you want to be inferior here and you want to be posterior, and that's how the puncture looks. See the other view, we are already in appendage, and you can see the catheter in upper pulmonary vein, which is also seen in fluoro, and we have already taken the device in. So this is how you enter. Now, just out of curiosity, if you want to do a BMV, where would the puncture? See, this case could be having a PFO here, but we wouldn't want to enter through PFO because the rest of the procedure becomes complicated. So if it is BMV, my puncture would be somewhere here in the midpoint of this septum, and it would actually be an aortic will. I would want it to be mid aortic, not posterior aortic, mid aortic. So based on this, you could decide. And if you want to do a mitral clip, you could be a little more superior. You could come in the upper part here. And again, you want to be mid aortic, not too posterior, but mid aortic. So multiple procedure, multiple step can actually be done. So once you master it, you could do whatever you want. You could puncture exactly where you want, and that helps you. And this is not difficult. Advantage of this, everything done in AP view. Half the heparin is given. You're not worried, because most of these diseases are more thrombogenic than classical BMV because they're elderly, there is AF. So, you know, that's comfortable. Even if the patient is on WARF or NOVAC, you can do multiple punctures can be done. It becomes very safe. You are just taking 10 extra minutes just for, you know, Dexmed or, you know, dexmedetomidine to go on and measure. And this is how you do this is a LA closure. So at this point, we also measure the LA carefully and do the procedure. So also understand how much the therapeutic echo helps. See here, you can see this was an amulet case. You can see an amulet which forms a beautiful, like gola like formation, and you know where you are exactly based on your echo, and slowly you open up the device, position it in the right position, and then deploy the device. So this is our LA closure is done. But the key to this is septal puncture. With amulet ACP, it's little more forgiving, but if you're using a Watchman, if your septal puncture is bad, you might still be able to enter LAA, but to orient that device well becomes tough. So remember, the first important step is LAA in septal puncture, and do not, if you think your puncture is wrong, take one more puncture and do not take much time. And also understand where you're going to do this. This is a device which was deployed. We were confident of its position, and then we release it. Okay, and this is how it looks. Also re-emphasizing the importance of echo in these cases. So always, any of the structural intervention, one person cannot train themselves. Make sure you have a partner, could be one more cardiologist, could be a sonographer, but who understand what you are doing, and together they can help you. Because once that person is good, all you have to do it is quickly do the procedure. Your procedure time comes down. They know what they are saying. You know what you are doing. So it becomes much, much easier. Most of the time nowadays, it's just femoral venous puncture. There is no arterial puncture. You can give any amount of heparin, and you are, they can also tell you whether you're going deep or going away from this position. Now going to mitra clip. Again, it's a very important procedure. So this is a quick video to show how it is. It's been, soon there is a registry which is, it's already been done in India, and soon there is a, there's going to be a multi-center registry for approval. It's it will be like more like a post procedure follow up. Here again, we need a septal puncture. This is just a cartoon showing the septal puncture to be done at the mid part. You enter LA, make sure you are comfortable in LA, and then you pass your catheter which you want to pass using the dedicated catheter. Most of the time when you want to do exchanges in LA, it's preferably done in the pulmonary vein, like any big sheath. And this is how the mitra clip looks. This is a case of a valvular prolapse with MR, and it's a central MR. So you go down here. This is much, much more echo intense than transmitral valve replacement, or this 3D echo will be needed, not only in the beginning, in multiple times. So in the example, what they're showing is they're holding the valve, they're going to look at MR, they realize, although it formed a two orifice, probably not much stenosis, but when they do color, they realize that MR is still there. Okay, so it's not about holding the valve, it is about holding it optimally. So you could do many times reposition and find the most ideal position, grasp the valve, and once you do that, it's quite robotic later. There are multiple knobs and multiple procedures. It's quite robotic, it's time consuming, but that's the part which needs to be done, and that's how you implant this procedure. So next, obviously, is for mitral valve replacement. Typically now it has been an old MVR degenerated mitral valve with reverse positioned aortic valve, which is used, which could be which has to be a balloon expandable valve. So it could be a Sapien or now Merrill, but position formed ulta, the TAVI valve. And when it is done, again a septal puncture, but in the mid septum, TE guided, obviously, you enter LA, and then in LA you can take the you need to dilate the septum most of the time, because the sheath is much bigger here and your valve has to go. You cross the valve, you enter LV, and you expand this wall inside the ring, and that's how it looks when you expand. Other There are many procedures. One interesting procedure is a paravalvular leak. Again, if it is a lateral paravalvular leak, again it depends on the site of paravalvular leak. Extremely echo sensitive. You need a good 3D echo with a person who can do extremely good 3D echo. So the message is, if there is a structural intervention, have a partner who is good in echo, who is committed to echo, and that's when you will be able to do it better. So if it is the lateral paravalvular leak, ideal septal puncture will be superior in the fossa ovalis, little upper part. You will be easily able to enter LV and then put a device. Typical device which are used are AVP2 or AVP3. If it is medial, this becomes extremely tough to do through the septal side. Then apical puncture could be done. Apical puncture, enter, and then do the push the device. That's very simple, and the LV itself is closed using a device. That's something which we need to master. Now, there are lots of difficulty in septal puncture, but most can be managed if you have a good TE. Severe kyphocoliosis, I mean, there are masters who can do it just under fluoro, but any such case, we have a low threshold for a TE guided puncture. Unresolved septum sometimes becomes very difficult. Yeah, one more thing what you face is, what if you try to puncture under TE guided and the balloons, the needle starts slipping? That's common. You will see it. At that point, you have 2-3 options. One, inside the broken barrow needle, you can take the opposite end of the 014 wire, coronary wire, and just puncture it, and then take the normal end of the 014 wire, and on that extend your the broken barrow needle. I've done it a couple of times, works wonderful. So it doesn't move at all at this point. You could also use a cautery towards the usual cautery. Once you know that this is found the end of the broken barrow, you could touch a cautery, and easily the broken barrow needle enters LA. So these two can be done if it is difficult. I think the left side, it's a little tougher because it goes, always it's been the right femoral vein which is the best for septal puncture. It becomes a little tough with the left. You may have to bend your needle a little more, angulate the person little to get the right position. Jugular also can be done, but the needle has to be bent little more if you're doing jugular, and you need to understand. Remember, whenever there is a difficulty, go trans echocardiographic. Your chance of error and complications will come down markedly. And also, my advice to people is that if you think that it is, like I was telling in the beginning, see, BMV is something which all of us do most of the time. Some might do a lot BMV. Some, once a month is something which typically most intervention will do, even in a private setup. 1 or 2 BMV a month is something which most people end up doing. So whenever you do it, try TE guided. Like as I was telling, there's no harm in doing it. You could use a pediatric probe, Dexmed. Maybe you can avoid corona time if you're worried about corona this time. But once corona is over or vaccine is available, when you're comfortable, you could actually do a TE guided septal puncture, but mastering TE guided septal puncture will be something which is going to take you a long way in other things. Complication, yes, everything is possible. I'm sure most people know. ASD itself is not a big deal because it is smaller. Very rarely, if there is a RV dysfunction, it depends on the procedure you do. If there is RV dysfunction and you expect a right to left shunt, you may have to use a device to close. A typical small left to right shunt is not a worry at all. Stitch phenomena rarely occurs, especially when you are doing this. This is dangerous, might need an emergency surgery. So always think before pulling out, reversing out, any pericardial effusion, you will understand this. Aortic root staining can sometimes occur if it's just staining. This is all the problem of, confident fluoro-guided puncture. And you believe me, complications don't occur early on. Early on, you're much more careful. The mid period is where the complications are more likely to occur. When you are very confident of your procedure and you think you cannot have complication, that's when you have likely to have a complication. Later, more less confident you are, you know, and more careful you are. So with this, I think I will stop my talk, and I'll be happy to, you know, answer any question, Ravindran. So any questions or any this?
Actually, we don't had any questions, separate this thing box, chat box for questions.
Chat box is open. Yeah.
Yeah, it's open.
Let me see. Yeah.
No, sir, no, we have not
No,
increased
zero
the
questions,
box.
Ravindran.
No, you made
I
it.
think everybody is hungry.
No, sir. Most of us have done it with already.
I had your dinner. That's why you kept it at 9, I think.
Yes, sir.
So I
Regarding
can see Suraj is not come, I think, no? Anand is there. Hello, Anand, how are you?
I think he's logged in and staying away.
Okay.
Sir, regarding the usage of the pediatric TE probe,
Yes.
I think that will be much easier, and it's a
Yes,
simple
yes.
common
It's
sense to use that. Is
yes.
there any difficulties in using that?
No, actually not at all. No difficulty at all. Only availability of the pediatric T probe. Not all centers might have. If you have it, my advice will be switch to pediatric T. They are also 8 to 9 megahertz. The adult is also 8 to 9 megahertz. So how does it matter? No.
The
And
length and
esophagus
the,
image is extremely good. You get completely information which you have. Try it next time. And
okay.
esophagus compresses on itself. No, it's not going to remain distended. So there's practically no advantage of using adult T probe. Actually, if you have pediatric, use pediatric T probe. The most key message is whenever you're doing a BMV, use it. You know, master it step by step. Master. Do a, you know, it's like figure of 8 stitch will be a must, which, you know, most of the time when we do, we should have figure of 8 stitch.
Yeah.
You know, each step is to be mastered in your mind. Procedure, you know, like one great person told me once, was procedure is actually done multiple times. Once in your mind before you actually do it, once when you actually do it, you keep thinking about. So procedure is something which we need to think, split it, and then do the multiple step. See, like if you want to start TAVI program, 2 things you have to do, as I told. Learn per close. All your angioplasty start per closing. So that is, you know, otherwise the day of procedure, you know, you're struggling with per close. And then you're struggling to enter because your mind keeps telling you, can I enter? Can I enter? Once you know that entry in a aortic valve is never an issue. You know, there's no case where they have failed entry, and you have entered yourself multiple times, measured, and you know that's how it is. You know, it helps. So here I think the key message is do settlement under TE without intubation. You know, the worry is intubation, but do it without intubation.
Sir, I think pediatric probe will even much more make the patient comfortable. And even for PPE, can we use the pediatric
Sorry,
probe?
Ravindran, I'm not able to hear you. Yeah.
No, sir. I'm
Uh,
asking that this pediatric probe can be used
uh.
for even the routine TE also.
Yes, it can be used to routine TE. This really, I don't find any reason why adult TE probe should be used, but we are used to it. In KMC, when we started this, you know, LA closure, that's when we thought, why not switch to pediatric? We had a beautiful pediatric. Nowadays, you know, pediatric probe comes with 3D also. Earlier, it was not available. Only adults probe at 3D. So now there is no reason to use adult probe. If you have pediatric, you can do. So I think there's a question from Dr. Anup. Yeah. Can you explain the site of atrial puncture for yes? So for a BMV, it will be in the mid-septum. See, whenever we talk about septal puncture, it's still in the thin area. It's not in the thick area as much as possible. But the thin area of the septum, you know, when you do TE, you realize is quite long. So anywhere where you want to enter LV, the puncture is mid or superior. So BMV is mid, both in mid in aortic and the bicable view. These are the two views: aortic view, bicable view. You want to be mid and you want to enter LV. When it's mitra clip or a paravalvular leak, you want to go little more superior because you have more space to enter LV. If you want it to be for a proper mitral, like a transmitral valve, again you want to be mid. If you want to go to LA appendage, you want to be posterior inferior because it's a left anterior structure. So bicable view, you are near IVC, and in aortic view, you are away from aorta. To go away, you will actually turn your catheter clockwise. So you go away. And then if you want in a pulmonary vein, you don't want to be that posterior, yeah, so it will still be inferior in bicable, but in aortic view you want to be in mid because you want to go to multiple this. So I think there are some other questions, no, Ravindran?
Yes, sir. Yes, sir.
Yeah.
Is it-
Giant LA, transjugular, yes. Transjugular, yes. If you you need to bend the needle much more if you want to go transjugular. It's not difficult, but the problem comes with catheter and the size and those technical issue. Pediatric broken barrow with the pediatric sheath will be better if you are using the transjugular. You may have to press the, you may have to reshape the needle so that it comes. Otherwise, it's not very difficult to do a transjugular puncture. But more important probably will be to learn a T-guided puncture. Femoral to jugular, yes, femoral is preferred for many, many reasons because it's not just the puncture, it's something which goes beyond that. Most of the time, your 14 French sheath and 16 French sheath, which you want to take, they have to go through femoral. Jugular is not very ideal when you want to do a balloon. See, the earlier when they had the Joseph needle and balloon, they used to use a peripheral balloon actually. Technically, something like a double peripheral balloon. It was not an Innova balloon which went through the jugular. So that is why femoral puncture is almost always preferred. So femoral is the septal puncture is always femoral unless it's like TAVI is like always femoral. Lots of procedure, the complications come down once you know the preferred approach. Yeah. Entering LA, you can do it in any way, but when you are here, it's not about entering LA. It's actually about the what follows when you enter LA.
Sir, I have one more question, sir. Regarding the TE for the TE guidance to follow the puncture. More often than not, it is difficult to track the needle or the catheter. It's only the tenting we could see. Is that enough, sir? Is that what we have to go by, or we really need to trace the needle because it's only single frame? The needle is also moving. The
Correct.
probe is also being rotated.
Correct.
And what we exactly see, we just see I think I have done a few cases and I understand that we could appreciate only the tent, which is actually a 360-degree tent, and one of the cut will definitely cut through there. And
Correct.
the
Correct.
maximum indentation can be picked up. If at all.
Correct. So what happens, Ravindran, is you can see the catheter sheath in SVC. That's not difficult. When you come near SVC, you will be easily able to see the catheter. But as you come down, as you rightly said, that you don't see the whole catheter. Very rarely you see the whole catheter. And as the tenting, the perfect tenting actually can be seen. Because once it tents in that particular point, you can. Even the video I put, believe me, Ravindran, we and our Dr. Rocky actually searched through a lot of video to find a perfect septal puncture video, but we couldn't find because most of the time it's so quick that it's done, and probably we have not recorded. I'll keep a follow-up on recording some of them. But tenting can be seen both in this and other procedure. See, once you see the tenting, that's where it's going to enter, and that's what you want to see. But little more cooperation between you and the echocardiographer actually works wonder, So our procedure time from 1 hour for LA is actually come down to 15 minutes now, So that's the big advantage because then thrombosis, all the complication comes down. But this has come over years, Initially, see in KMC, I had a person who would to do fantastic echocardiograph and it was very, very smooth. But I moved alone here. No, I didn't get my echocardiographer. So here we had to restart it. But now Dr. Kavya, who is our pediatric cardiologist, has taken a special interest in this area. And now it is like a cakewalk. Things are much, much easier. We communicate each other, so we know what's happening and it's difficult. Recently, I had a PFO case and where one day I had to postpone because, I thought it would be easy. Most PFOs, things just go across, but this one was tough. We didn't puncture, but it needed the broken barrow needle to be there to give that this. A tunneled PFO sometime to cross it becomes actually difficult. So among the many PFO closure, this one was tough. We are again one center. I think last 8 months we have done 5 or 6 PFO closures. So any young stroke we actively look for PFO, and if there is a PFO, we close. Typically it's just 15 minutes. You don't even need T because the wires just walk through. She's just walk through. Things are very difficult. But the last case we needed all the imaging and all that. I took him back because I thought, I'm not able to enter. I didn't want to puncture and enter. Then we redid his echo. I went through the image and I realized it is PFO. There's nothing else. We thought there is a pulmonary venous anomaly because I could see something going up and down in the angio. Redid a CT, realized there is no other problem. This is the only problem in an 18-year-old. This patient was 18-year-old with 3 strokes. So we just couldn't give up on him, and then we did the PFO closure. But the importance is the combination of imaging, and I had to do it twice. First day I did, I thought it is maybe something else. Am I missing something else? Then did everything and came back and then did the PFO. It's again a very rewarding procedure, and look for it. Just you need to talk to your neurologist. Anybody less than 45, have a good echocardiographer. That way, our team is good. Our sonologist in echocardiography does wonderful contrast echo. Any problem he would have done, recorded, kept it ready, and see that, and you're able to do. That's one procedure which is quite rewarding. And somebody asked the question about aneurysm. Aneurysm things flap a lot, but once you tent and maintain the position, if you start pushing, it will go up. At that point, what you do is hold it there, use the opposite wire of your coronary wire, puncture, just puncture, don't push it all the way, just puncture and remove it. Don't pass your needle on that. Hold that puncture, pass the usual wire of coronary wire that will now go around in LA. On that, take your needle. If not, just hold it there, touch your cautery with the usual 30 the heat, just touch on the poof, it moves in. Actually, if you do, it's very interesting. I hope I'll try to find some video to do that. So you can easily do these two things to enter. We don't have RF and all that here, but you don't need it. So first attempt you do, you find it slipping, don't, try one of these methods. And rarely you can go through PFO and do the procedure. I had one case where it was a watchman case, and the ASA was pretty bad, but there was a PFO. So we went in and we closed the LA with watchman, but I didn't close the PFO. Actually, we were doing for anticoagulation, was not tolerated. But the patient never had a stroke to start with. It was AF, and indication was anticoagulation. So I didn't close the PFO in that patient. So PFO is not closed because it is there. It has to be closed only after some sort of stroke or some manifestation. Whereas LA closure is other. It's for AF. Whoever is not tolerating anticoagulation or doesn't want to take it, or you feel they're high risk for any other reason, it's a good treatment.
Sir, one more thing, the TE you have shown are all, I think it's a 3D TE because you had shown orthogonal planes simultaneously.
Okay, in our view, no, ours is, what we have is most TE machines have a explain, Ravinder, explain. That's very useful. If your TE machine has a explain, get a proper view, put a explain. For septal puncture, it is very useful. Also, it is very useful to measure LAA. You get 45, put explain, you get 135. You get 0, put explain, you get 90. When you do that, especially 135 is a difficult view to get if you're just adjusting yourself. Explain helps. So most machines now do have explain. So you don't need a 3D TE, you just need a explain. Our center also is actually has echo navigation. So, the echo images fall on the floor, so we know the exact point where we are puncturing you on the floor. But all that is not needed. All you need is, mentally have a picture of how things are. I think there was one question, Ravindran, about giant TSP is septal puncture in giant LA, no? Yeah, if you're doing it under TE guidance, it doesn't matter at all because you know where you are. If you're doing under fluoro, there is a double mark. Giant LA with the compressed RA is a problem. Giant LA with both giant is okay. You need to come little more down. Always try to be in the horizontal, a junction of horizontal and this. When you bring your needle down, You come from SVC, there is SVC, then you come to RA. All this time your catheter is vertical, it's vertical. As you come down, it becomes horizontal. So junction of horizontal to vertical is where you have to puncture. So imagine there is a giant LA. Which area would it like to press? The softest area is actually the fossa. So since it is the softest area, that is the area which is likely to be positioned in that, it's pressing it. That is the one which will be in that position. So if you puncture at that position, it works very well. That's what I realized once, after doing LA, that's what we realized. And that's why I don't use aortic catheter at all, because we have to be very away from that. And I want to come at that point. Once you enter through that point, everything is very simple. I also keep my, the BMV catheter turned like this, and all you have to do is little anti-clockwise, and it stops. That's when it starts pecking, and you hold the dilator and just push the sheath inside. It goes very easily if you do this. If your puncture is good, things are very easy.
There is one more question.
Nobody else wants. Yes, Ravindran?
The small LA patients.
Small LA, yes. Small LA, you are likely to be more vertical if you are doing it. One more thing which could help, even if you are not using TE, ask somebody to do a TTE for you. Just a transthoracic echo. That can also tell where the needle is. Not as much as the echo this does. If they can show you where it is, it does help you where it is. Big RA, compressed LA is the toughest for septal puncture. But TE guided, nothing is tough, because you know what you are doing, and it becomes tough. There are cases in BMV we struggle, but nowadays I don't struggle too much. First time it doesn't go, I ask. By the time Dexmed is anyway started, so that takes 10 minutes. By the time you start, Dexmed is started, so it takes 10 minutes. By 10 minutes, if you have not done it, you have a TE probe in. It makes it very safe.
You told that your
Ravindran, again, I think we are not able to hear you.
Yes, sir. I'll talk near the mic. Is it fine?
This is good. This is good. Yes.
Yes, sir. So regarding, you told that your echocardiographers were easily picking up PFO.
Yes.
Is it using the color Doppler only, or routinely in these patients you do this bubble contrast?
All of them we do bubble contrast. All our patients who are young, who needs, we do bubble contrast in all of them. Not in everybody. Anybody less than 45 has a stroke, gets a bubble contrast done. 60 up to 60 without any other risk factor, not a hypertensive, not a diabetic, but has a stroke, again gets a bubble contrast done. So he's quite good at it. The images, again, it's very important to record that bubble contrast and replay it. Otherwise, bubbles just disappear. You don't see them, you are looking at something very impressive, but the patient is trying to do a Valsalva, the image goes up, and it's not easy as we do. So what he does is he does beautiful image, records it, plays it, and you see the bubbles actually going through the PFO and entering into LALV. So it's very important to record and play it back to actually get it here. Especially in the little lesser one, the simple ones where there's a huge number of bubble, it's a different way. See, I also had one actually doctor was, sometimes you don't know why they start getting recurrent strokes at once. This was a doctor who was nearly, I think, 55-56-year-old. In 3 months, he had 3 strokes, and neurologist went on increasing the anticoagulation from aspirin. INR kept on going up. Then aspirin was added, clopidogrel aspirin was 75, 150, 325. You know how they increase it. And then Clexane was given anytime. So this patient, I did a TE, and first attempt, we didn't find any bubble at all, actually. It was difficult, because even for a doctor to explain a Valsalva is not easy. Third time, with a great difficulty, I found the bubble in LA. Okay, and then we went ahead and closed. Now it is 6 years. He has not had stroke. He's just on, single antiplatelet now after all that. So sometimes these are not as easy as think. Everybody need not have aneurysms and PFO. So people with recurrent stroke look for, TE guided or bubble contrast. It really helps. Yeah. And young patients, this is something which is needed, you know, because they are so scared after that. War cannot be taken for life. Yeah.
Dr. Ganesh, you want to add on anything?
Again, Ravindran, is it only me or others are also not hearing? This is better.
Dr. Ganesh, could you you have any questions to ask?
I think he didn't hear you, Ravindran.
Okay. Don't know, sir. Dr. Ganesh, are you there?
Yes, Ravi, you are not audible.
Yeah, okay, sorry. You have any questions to ask or anybody else you can please post or
So almost all the questions have been asked and it's been very
okay.
nicely attended. Almost everything he has covered in the lecture itself. And again, he re-clarified everything. It was a very nice, excellent lecture, sir.
Thank you.
Okay, sir. Then I believe we will end the session now. Sir, Arvind sir, are you there, sir? Dr. Arvind? I think we can end the session, sir. Thank you very much for making. Thank you very much for making this presentation very lucid and useful for most of us. Actually, nowadays with the Zoom meeting, we are getting more attendees, and I believe that it is more reaching more people and making things useful for many of these attendees. Thank you very much, sir. And Ganesh, you want to tell anything?
Well, I think it was a very nice presentation, sir. You talked with a very good flow because you are talking on a topic which you are doing day to day, things which are being done every day. So that is very easy, and you gave very nice and interesting tips, especially in difficult situations. And I think we should start applying all those tips practically. And then once we get adapted to those things, and as you said, we will be able to catch up with these procedures. Thank you very much, sir, for this elaborate presentation and giving all those wonderful tips.
Thank you, Dr. Ganesh. Thank you, Ravindran.
Thank
Have a
you, sir.
great Sunday. Yeah.
Thank you, sir. Same to you, sir.
Okay.
Thank you,
Bye.
sir. Thank you very much. Stay safe, sir.
Sir, tea additional, sir. Meeting close பண்ணிடலாமா sir?
Yeah, we can close it. I think we can
Okay.
close it. Yeah.
Okay, sir. Thank you.
Thanks for all the audiences who have been. Thank you.
Thank you, sir.